but the difference in the diagnostic yield was not significant statistically, meaning both the techniques were good enough to produce the diagnosis. Interestingly, they also found that the semi-rigid thoracoscopy was tolerated better by the patients. They required lower amounts of sedation whilst performing the procedure.
Zafer seni bunun yanına göndereyim dedi.
There was one other technique that has been evaluated. This is called a mini thoracoscopy. This is the use of a rigid mini thoracoscope, which was compared with the
Mini
semi-rigid.
torakoskopi dedi. Semi-rigid. Yani tıbbi kelimeler ya. Ben anlıyorum. Tamam da cümleleri onlara ikisi.
So we've got another speaker as well, is it? The background?
Yes, I'm sorry.
No problem.
Arkadaşlar lütfen mikrofonları kapatabilir misiniz? Çok rica ediyorum. Lütfen mikrofonları kapatabilir misiniz? Teşekkürler. Please go ahead.
No problem. Thank you very much. I thought there was a young speaker as well. There's a little kid speaking in the background as well, which is great. Here, in this particular trial, they compared this new thoracoscope, rigid mini thoracoscope. I don't know whether it's available in Turkey. This particular thoracoscope is used, and this was compared in New Delhi, a study with the semi-rigid thoracoscope. This is called the MINT trial. And what happened with this particular new mini thoracoscope, the diagnostic yield was found to be slightly lower than the semi-rigid thoracoscope. The number of biopsies was similar, adequacy of biopsy was similar, but the diagnostic yield was lower with the mini thoracoscope. The biopsy size, though, with the mini thoracoscope is actually bigger than with the semi-rigid thoracoscope. The use of the semi-rigid thoracoscope, however, provided with greater patient comfort. So if you look at operator-rated procedural pain, it was greater with a rigid mini thoracoscope, and it was better tolerated with a semi-rigid thoracoscope. So in other words, rigid thoracoscopy in many forms is very similar in diagnostic yield as semi-rigid thoracoscopy, but semi-rigid thoracoscopy is tolerated better under local anesthesia when you perform the procedure. One advance, the topic today is about advances in medical thoracoscopy. Over the years, one particular advance we have seen is the use of narrowband imaging with a semi-rigid thoracoscope. So in bronchoscopy, presumably many of you use narrowband imaging, although it has been more extensively used in GI endoscopy. With the bronchoscopy also we use narrowband imaging. The same principle was applied with the semi-rigid thoracoscope. What it showed is that when you do not have an obvious lesion in the pleura, when you do not have actual masses in the pleura, if you look at the vascularity, capillary architecture, there are some abnormal patterns of vascularity which appear before the lesions become evident. So there are two studies, one from Japan, another from Berlin by Nicholas Schoenfeld's team, showing that when you pick up this abnormal vascularity, this may be another method to make a diagnosis early of abnormal tissue and potentially with mesothelioma. Mesothelioma, as you know, can be notoriously difficult because it is a patchy disease, one. Second, unless you take the whole thickness of the pleura, you might get a false negative result. A group of thoracic surgeons from London showed that even by the hands of a thoracic surgeon, a thoracic surgical biopsy with a mesothelioma can sometimes give a false negative result. With this in mind, there are a couple of operators in Singapore and Japan showed that you could use an insulated tip diathermy knife to make an incision so that you take a full thickness biopsy of the pleura, like this. So this is another advance which has been tried. Requires a great deal of expertise and not without complications. So you've got to think carefully before performing it. Another option is to use cryobiopsy, cryoforceps biopsy, or cryoprobe biopsy. Now, a number of studies have been carried out, small studies, admittedly. One, Alice Rosman's team from Slovenia, then one from New Delhi, and another one from China. What is involved? Some of you may be using cryo for debulking of tumors, maybe using cryo for biopsy, endobronchial biopsy, for foreign body removal, for interstitial lung disease. So this is the use of a cryo probe in this fashion to actually take a biopsy from the pleural cavity or the pleural lining. This is Alice Roseman demonstrating the technique. He's very kindly lent me this video. So you can see by the use of cryo, you can take bigger biopsy samples potentially from the pleura. So this is pleural cryobiopsy, another advance which has occurred in thoracoscopy in the last few years. Now, the latest technique that has been tried is by Joke Anema and his team in Amsterdam, where they have evaluated the use of optical coherence tomography and confocal laser endomicroscopy. This has been tried in bronchoscopy, it's been tried in relation to bronchial thermoplasty, and also in the pleura, as they have demonstrated very nicely, because mesothelioma, as I said, and certain malignancies are patchy diseases, and you take biopsies, sometimes when you take a biopsy, you might miss the diagnosis, and therefore they have shown that you could use potentially a needle, a confocal probe, which will tell you which is the target area to be targeted to get the maximal diagnostic yield. This is yet another advance in thoracoscopy. In the second section, I'm going to show you now a step-by-step guide for thoracoscopy, but touch upon another advance also which has occurred in this particular technique. This is a traditional semi-rigid thoracoscope. If you have used it or if you have seen it, you will find that it looks and feels and functions exactly like a bronchoscope. The attachments are the same, suction is the same, the working channel is the same. The only difference is it is shorter. It's only 27 centimeter in length, and the last 5 centimeter, distal 5 centimeter is flexible. The outer diameter is bigger than a bronchoscope because it's 7 millimeter, and the instrument channel is bigger than most bronchoscopes, except for the large therapeutic bronchoscope, and that is 2.8 millimeter channel. The angulation is 160 degrees upward and 130 degrees downwards. And you connect it to standard video processors, and it's autoclavable because you don't want to cause any problem with infections. Single operator, we do the most of the procedures single operator, single puncture, usually in the mid-axillary line in the lateral decubitus position. Only monitoring you require is oxygen usually. So what you do is enter the pleural cavity, drain the fluid to dryness, as I'll show you in a minute, and then examine the pleura all over. You can go all over the pleural cavity, examine the pleura, take parietal pleural biopsies. Many of these biopsies in the studies have been taken using the Olympus thoracoscopic biopsy forceps. But those forceps are good, but they're smaller. I tend to use this forceps, which is an oval fenestrated forceps, which is bigger, with a needle. And this forceps usually is used in gastroscopy, but I've tended to use this for thoracoscopy. And it's not something that the company recommend, but I would certainly recommend because it gives you better grip of the pleura and you get bigger sample. And finally, you would do a talc poudrage at the end of the procedure and insert usually a 24 French drain. The drain is removed after re-expansion. I tend to remove usually after 24 hours. Where the lung is trapped, I would also place an indwelling pleural catheter during the procedure. So the most important thing that you need to know to perform thoracoscopy is ultrasound. If you can perform ultrasound on your own, on the table, that is what you got to do. So you identify the diaphragm, the lung, the pleura, and then you introduce the trocar through this space. Makes it completely safe. Even small effusions can be accessed by introducing a needle to aspirate and then inducing a pneumothorax potentially, as I'll show you in a minute. People ask me often, what is the risk of thoracoscopy? What will happen if it starts bleeding? But actually, bleeding from biopsy during thoracoscopy is incredibly rare. The bigger problem, if you ask me, is infection. And we need to avoid infection, and every possible effort needs to be made for that purpose. So this is how we use a sterile field when we perform thoracoscopy to avoid infection. Then step by step, you need to give adequate analgesia and anesthesia. We give sedation in the form of midazolam and fentanyl usually for local anesthetic thoracoscopy. Then we introduce the local anesthetic, which is 1% lignocaine usually. After that, we may do a blunt dissection and then introduce the trocar. You identify the spot, you find you locally anesthetize the periosteum or the ribs or the intercostal spaces, and step by step, after making an incision, just like you would place a chest drain, you would then introduce the trocar and perform the procedure. So here you've identified and confirmed that there is fluid, and so you're in a safe place to perform a thoracoscopy. As far as blunt dissection is concerned, after you've made the incision, it's important to use a blunt pair of forceps or blunt pair of scissors or artery forceps, narrow artery forceps, to make the channel, to create a channel and perform the thoracoscopy step by step. As far as the thoracoscope, introduction of thoracoscope and the handling of the thoracoscope is exactly like in the like with the bronchoscope. And when you enter the pleural cavity, you see these abnormalities. This person ended up having a tuberculous pleural effusion. This was a few years ago. And here you're using narrow band imaging during thoracoscopy to get a better view of the blood vessels. What does narrow band imaging do? As I showed you earlier, it accentuates the capillaries and gives you a clearer idea as to where you need to take a biopsy from. So it's high definition thoracoscopy, and then narrow band imaging as well is used for this purpose. An extremely important point to remember is, unlike with a bronchoscope where you would open the biopsy forceps, introduce the biopsy forceps, close and pull the biopsy from the lesion, with thoracoscopy, what you got to do is you got to take the biopsy forceps, open the forceps, close very, very, very slowly. And then once you've closed and you pinch the pleura, you do not move the forceps. Instead, you move the scope so that you start tearing the pleura. So that is what's being demonstrated in this particular video. As you can see, the pinch and peel technique. So you pinch and peel the pleura so that you get large amounts of tissue. For the next biopsy, you'll go to the edge of where you pinched and peel, and you start peeling in this fashion. So that is crucial to get adequate tissue and you get full thickness biopsy of the pleura. And finally, you have a dedicated talc, aerosolized talc, which we use to spray into the pleural cavity through the working channel under direct vision. So this is demonstrating the spray technique where you introduce talc into the pleural cavity. Very quickly, in a matter of 20 to 30 seconds, you will go around the entire pleural cavity and spray and complete talc purgage. And as I said, sometimes we also place an indwelling pleural catheter at the same time during the procedure with these two incisions. So this is a Pleurex catheter being placed at the end of the thoracoscopy. So what are the challenges? One particular challenge is that sometimes you do not have enough fluid to introduce air and create the space for you to do a thoracoscopy. In this scenario, we have the option, if the patient is fit for single lung ventilation and general anesthesia, we have the option of sending the patient to the thoracic surgeons. That is certainly an option. That's something we do. We work in close collaboration with the thoracic surgeons, and they would perform the procedure. An alternative, where the patient is not fit for GA, what do? Not fit for single lung ventilation. There, you can induce a pneumothorax, as is shown here, by using a dedicated pleural puncture needle, which was designed by Bouton, Christian Bouton in Marseille, and therefore it's called a Bouton needle. So this is how pneumothorax is induced, and then you introduce the thoracoscope through into the pneumothorax and very safely perform a thoracoscopy. If you want to perform a thoracoscopy, if you want to learn to perform a thoracoscopy, I would therefore say to start with a large pleural effusion first, so that you don't have this problem, you don't encounter difficulties while performing thoracoscopy. The latest kit, and because the topic is advances in thoracoscopy, I wanted to mention, this is hot off the press, a new thoracoscope, a new semi-rigid thoracoscope has been introduced by Olympus. It's not freely available as yet, where the outer diameter is a little bit larger than the existing scope, 7.3 millimeter rather than 7 millimeter. The inner diameter working channel has gone up from 2.8 to 3 millimeter. The angulation range has gone up to 180 and downwards to 130. In addition to that, this particular scope gives you a higher definition, as you can see, bright, clear observation with higher definition imaging. As I mentioned already, wide angulation range, narrowband imaging compatibility, and better images than narrowband imaging. You can use a larger biopsy forceps potentially, and it has a one-touch connector. So that's another advance that we see because it's got HDT, HD images, and narrowband imaging as well. Coming towards the end now, I'd like to tell you some practical points. How come thoracoscopy has become so prevalent? Certainly in the UK, in many other countries, in the US, Japan, China, etc., in India, for instance. The reason is this sort of a patient. This is a real patient that I was called to see last Tuesday afternoon, Tuesday evening. He's a 36-year-old gentleman, completely fit and well. He works as a roofer, repairing roofs, and 2 to 3 week history of feeling unwell, breathless, and weight loss. He came to A&E, emergency medicine, and then he was complaining of these symptoms. Therefore, they did a chest X-ray. The striking finding here is a massive pleural effusion, but in addition, the shift of the mediastinum. Whole mediastinum has shifted to the opposite side. The trachea has shifted to the opposite side. So quite clearly, this is a semi-emergent situation. We need to do something. Besides, projected on this is some other abnormality in the lung as well. So what we did is from there, from A&E casualty, we took him straight to the CT scanner. When we did the CT scan, no doubt we saw the large pleural effusion, completely collapsed lung, but in addition, a mass in the mediastinum. So the differential diagnosis here will include lymphoma, potentially, thymic carcinoma, teratoma, lung cancer, could be mesothelioma because he's a roofer, he's been exposed to asbestos. So all this was there. So what we did was next morning, we admitted him, and the next morning we took him for a thoracoscopy. So last Wednesday, that was a week in advance. And the biopsy results showed that it was a high-grade lymphoma. We got the result on Friday, and on Saturday, he was started on treatment. He had a 3.5 liters drained from the pleural cavity. He had an indwelling pleural catheter placed, and everything has been addressed in a matter of 4 or 5 days. So that's where thoracoscopy is exceedingly effective. We see these patients, we do the procedure, get the diagnosis, start treatment. He's already well into the treatment for his lymphoma now, a matter of 1 week. So in conclusion, if you want to perform thoracoscopy, if you want to learn to perform thoracoscopy, there are certain requirements. You need to train to do the procedure properly. You need to, not just yourself, but the whole team needs to train to do the procedure properly. It is a team effort. It is not a one-man show. You might be the person doing the final, taking the biopsy, but you've got a whole team behind you. So everybody's got to train. There could be a simulation of settings, simulation training of the procedure, how to manage complications. So we pretend that there is a complication and simulate and discuss. We should always use a safety checklist for any procedure, for interventional bronchoscopy, for bronchoscopy, but certainly for thoracoscopy. I presume all of you use the WHO safety checklist. I have emphasized in the video the importance of sterility. We cannot afford to end up with an empyema. That's the worst possible complication. Should we be giving prophylactic antibiotics? The jury is out because there's no clear evidence one way or another. There are some studies that show that it doesn't make too much of a difference. What is more important is to maintain an aseptic field, an aseptic technique. Sedation and analgesia for the patient's comfort. They need to have adequate sedation and adequate local anesthesia. What we do in our hospital and in many centers is to limit the number of people who do thoracoscopy, specialist operators only. Not everybody should be doing thoracoscopy. Crucial, absolutely essential, I would say, is the use of ultrasound on the table just before the procedure, so that you don't make any mistake as to where you enter the pleural cavity. And although bleeding following biopsy is incredibly rare, you need to have a standard operating procedure and you need to have a bleeding protocol. What are you going to do if there is bleeding? How are you going to cope? How are you going to manage it? For that, you need this bleeding protocol. So you've got to be prepared when it comes to thoracoscopy, or indeed for any other technique in medicine. Thank you very much indeed for your kind attention.
Thank you, Dr. Munavvar. Is there any question from the audience? I have one question for you. Is indwelling pleural catheter routine procedure after thoracoscopy in your clinic?
Not a routine procedure. What we do is, if the lung is severely trapped, or if the patient is an elderly patient who has traveled from a long distance, because if you do the thoracoscopy, talc pudrage, and if they get a recurrence, it'll be quite difficult for them to come back for the procedure. What we do is place an indwelling pleural catheter. However, to answer the question whether it should be a routine practice or not, we are doing a study in the UK. We were about to start the study. It's called the TACTIC trial. So it's a randomized trial. In one arm, all the patients will receive an indwelling pleural catheter at the end of thoracoscopy, along with talc pudrage. In another arm, they will not have the indwelling pleural catheter. This is a study which we were about to start last February, March, and suddenly COVID hit us, so it's got delayed. So that study, TACTIC study, will answer that question whether it should be a routine procedure or not.
Mm-hmm. Thank you. Our colleague, thank you so much. Also,
Dr. Munavvar, thank you for joining our seminar series today. That was a valuable lecture for our researchers. I would like to thank you on behalf of them. I have two questions, if possible.
Sure.
Have you ever seen an intense level of hemorrhage during the semi-rigid thoracoscopy?
Have you ever encountered hemorrhage during thoracoscopy?
Yes, major hemorrhage.
A massive hemorrhage after biopsy in thoracoscopy? Fortunately, I have never come across that.
Mm-hmm.
I've never encountered it. And if in the UK, we keep in touch with all the thoracoscopists. And I know of one report over the last several years ago where hemorrhage occurred in Oxford in one of the centers, Professor Naj Rahman's unit. And so nevertheless, we have a standard operating procedure to how to deal with the hemorrhage if it were to occur. The principles of management of bleeding exactly the same as any other type of scenario, where you make sure that you have enough ABC, airway breathing circulation, but locally in the pleural cavity, you can control the bleeding by trying adrenaline, or we have argon plasma coagulation available to control the bleeding. But in that case in Oxford, all that helped was a compression of the area where the bleeding was occurring from outside. So you could essentially compress from inside as well as outside. Theoretically, if there's bleeding despite that, you will need either surgical help, or more commonly or more effectively would be interventional vascular radiology intervention for help.
Yeah, another question, excuse me, regarding your opinion, how many thoracoscopy should pulmonologists observe to learn how to make it?
Okay, Again, a very good question. And it's a slightly difficult one because it is believed generally that a certain number is required. And some societies in the beginning started to advocate that you need to do about 20 procedures to be proficient. However, what we looked at in the British Thoracic Society is that it was quite variable. If you look at even with endobronchial ultrasound EBUS, we did a very early on, we did a study in thorax we published, which is a QSUM analysis, showing that every operator seems to learn at a different pace. And therefore, we insist on competency-based training. So everything from competency for thoracoscopy is competency for ultrasound, and then all the steps of thoracoscopy. And that competency-based sign-off is what we do to try and certify people rather than just focusing on numbers. But a general rule, it has been found that about 20 thoracoscopies are required to be able to perform the procedure independently and safely.
Okay, thank you. There are some other
We
questions.
yes, we have some questions for you. One question is from Dr. Akif Turna, who is a thoracic surgeon. He thanks you first. Then his question is, in what percentage of patients did you need surgical intervention by surgeons to control the bleeding?
Thank you very much, Dr. Turma. Very, very kind of you. No, fortunately, we've done in our center well over 1,000 thoracoscopies. We've never had to ask surgeons for help, but we are very good friends with the surgeons. We always work closely with them, and we keep them in good books because in case we need their help, we collaborate closely. So in our center, we've never had, and even in the UK comparison, collecting audit data from across the country, we are not aware of any particular, since we started collecting audit, any particular scenario where the surgeons needed to be involved. So we work as a multidisciplinary team. There are some patients that the surgeons would do the procedure, prefer to do the procedure because there's very little fluid, there is pleural thickening, the patient is fit for GA, single lung ventilation. Equally, there are patients who are have multiple comorbidities and elderly and not fit for turned down by the anesthesiologist, and therefore then the surgeons would refer the patients to me for a semi-rigid thoracoscopy. So that is how we work. Fortunately, there's been nobody who I needed to refer to the surgeons.
Okay, thank you. One question is from Fatma Nur, who is our resident. She thanks first, and then how often do you prefer thoracoscopy when the amount of fluid is small?
Okay, again, a very good question. So what we do is we do an assessment based on the contrast-enhanced CT scan and the ultrasound appearances. If the contrast-enhanced CT scan shows that there is a significant possibility of it being an abnormal pleural lesion, and if the fluid is only small amount, we perform a pleural fluid sample first, and then if it is still easily accessible, we would either induce a pneumothorax through that port and then do thoracoscopy, or we would do an image-guided biopsy, ultrasound-guided cutting needle biopsy. In some situations like that, and if the patient is young and fit, we would ask the surgeons, request the surgeons to do, a thoracic surgeon to do a VATS biopsy. So it's quite variable. We individualize and then decide what is best for the, of course, we involve the patient in the discussion and say, this is the pros and cons of each of these techniques.
Okay, one question is from Dr. Hüseyin Yıldırım. He thanks you very much. In our experience, the most common false negativity in thoracoscopy is detected in patients with mesothelioma. What could be the reason for this?
Excellent observation, excellent question. And this has been shown in literature as well, that if you find a negative result in patients suspected mesothelioma, like you say, a false negative result, And if you follow up those patients, number of workers have demonstrated before. Julius Jansen's work from Nijmegen in Netherlands also have shown that if you follow them up for about 2 years, roughly about 10% or 10 to 11% of these patients who had a negative result turn out to have mesothelioma more obvious and confirmed later within that around that 2-year period. And this has been shown even after surgical biopsies, even thoracic surgical VATS biopsies, this has been shown. So the reason for that, the main reason, I suppose, one is that you have a patchy process in mesothelioma. An initial bit, you do not, it's not evident as to where to take the biopsies, and therefore you may be missing because of the patchy process. That's the reason even thoracic surgical biopsies have been negative initially. It's the nature of the disease, but you're absolutely right. Mesothelioma is notoriously difficult and notorious to hide and announce itself a little bit later. The other aspect is whether we are taking full thickness biopsies or not. And taking full thickness biopsies may increase the diagnostic yield. That's one of the reasons why I showed you Yoko Anama's team's work about confocal laser endomicroscopy. Maybe that will give us, we will be able to get targeted biopsy. We await the results of the full study on that.
Okay, thank you. I see very thanks to you from our colleague from Mehmet Karadağ, Ahmet Mert Aydın. They thank you. One other question from Deniz Köksal. Dr. Munavvar, thank you for useful talk first. Is it possible or easy to use semi-rigid thoracoscopy in complicated PP or empyema?
Okay. Again, a superb question, Dennis. Thank you very much indeed. So with empyema, there are two aspects. First of all, with empyema, should we use thoracoscopy at all in empyema is a question, because, for instance, the ACCP guidelines say that you're better off not using thoracoscopy in empyema. It's better to refer those patients for thoracic surgical intervention, because they need to have a decortication type procedure very often. So that is the first thing, ACCP guidelines. However, the ERS guidelines, or ERS, or European operators, are more advanced when it comes to thoracoscopy, and therefore in France and Germany, Italy, etc., some of the operators use thoracoscopy for empyema. As far as semi-rigid thoracoscopy, it's an excellent question, because if you use for empyema, the only place for semi-rigid thoracoscopy will be very early empyema, where you can do effective drainage. In complicated empyema or advanced empyema, there is very little role for semi-rigid thoracoscopy. What we tend to do with those sort of patients is refer them straight to our thoracic surgeons. It's much better for the patient if the thoracic surgeons handle those sort of patients.
Okay, thank you. Professor Ülke Yılmaz, who is president of Turkish Respiratory Society, thanks you for your excellent presentation. Another question from Dr. Muhittin Akarsu. Do you measure pleural pressure before thoracoscopy like 39-year-old lymphoma patients?
Again, a superb question. We do not, and most centers for clinical purposes do not use pleural pressure, but it's something that is being tried in the research arena in some centers. I'm aware of some centers where they're doing research in this particular field. So yes, whether it will give additional information, whether it will give additional information which is clinically and practically useful, we'll have to see and prove in these patients. But it's an excellent idea. Thank you.
Okay. I want to go ahead, if you don't mind. 3 more questions we have. From Dr. Hüseyin Yıldırım, should an ultrasound be done before every thoracoscopy?
Absolutely. I would never perform thoracoscopy without doing ultrasound by myself. That's the operator on the table. So actually, we get referrals from all over the place. We are a big cancer center, referral center. So what I tend to do is, they travel long distances. So previous day, in the morning, there'll be a clinic where we assess these patients, do an ultrasound, check whether they're suitable, and then do a workup, whatever is required, blood tests, etc., maybe echocardiogram, ECG, etc. And the next day we do the thoracoscopy. But in the first screening ultrasound we do, and then pre-procedure ultrasound on the table again to mark the spot, the entry point for the thoracoscope.
Okay, last two. From Binnur Önal. Thank you, Dr. Munavvar, for this comprehensive and illustrative presentation. My question is, do you routinely use pleural fluid cytology for patients with effusion and apply adequacy criteria like for minimum 50 to 75 cc to be able to make cell blocks in pathology?
Brilliant question again. Thank you so much. I think we always do a pleural fluid cytology, and we always attempt or use to perform a cell block as well. Now, if the suspicion is pretest probability of metastatic malignancy, such as adenocarcinoma, say from breast or ovary, etc., the diagnostic yield with pleural fluid cytology is very high. It's well over 60%, even going up to 80% in some situations. On the contrary, when it comes to mesothelioma, it drops to less than 10%, even if you use all aspects of cytology. This is based on extensive studies. And in those patients, we would proceed we'll very quickly to thoracoscopy. But in those with the metastatic malignancy, yes, pleural fluid cytology, cell block, enormously helpful. Small cell carcinoma also very often helpful.
Okay, thank you. The last question is from Dr. Şenay Yılmaz. In your clinical experience, which rare cancers except mesothelioma and lung cancer you have obtained from thoracoscopic specimen histology?
Again, a superb question. A number of unusual conditions that we have seen over the years include pleural fibroma, lymphoma. Every now and then they seem to appear during thoracoscopy. Bizarrely, some patients who have low risk of TB suddenly appear during thoracoscopy, very unexpectedly. A variety of metastatic malignancies from all over the place we have seen during thoracoscopy. Of course, there is the condition of pulmonary fibroelastosis you might have come across. Very rarely they have seen. There's a patient that we saw with sarcoidosis, which came out during thoracoscopy and repeated cultures. So the important thing is, when in doubt, it's best to also send a sample for biopsy sample for mycobacterium during thoracoscopy. So all of this we have come across.
Thank you.
Thank you, Dr. Mohammed. It is really excellent conference for us. We hope we will meet you again face-to-face in another meeting, in another conference, especially in Turkey. Thank you so much.
Absolutely. Absolutely. It's a highlight. Turkey is one of the most beautiful countries. I just love coming there. Semra has invited me so many times. You have invited me, so many of you, all wonderful, hospitable, warm people. I look forward to my next visit there. Absolutely.
We invite you after pandemic.
Pleasure on evening. Absolutely. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you. Thank you so much.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye. No, thank you. Thank you. Bye-bye.
Mehmet Hocam.
Hocam çok teşekkürler. Çok güzel bir sunuydu.
Biz teşekkür ederiz. Sağ olun hocam. Umarım yararlı olmuştur.
Kesinlikle çok yararlı oldu.
Sağ olun. Çok teşekkür ederim. Katılımınız, desteğiniz için bütün arkadaşlarıma içtenlikle teşekkür ediyorum. Güntülü teşekkürler.
Ben teşekkür ederim.
Bir sonraki
Sağ olun.
toplantıda görüşmek dileğiyle. Kendinize
Görüşürüz. İyi akşamlar.
Teşekkür ederiz
Sağ olun.
hocam. Çok sağ olun.
Çok sağ olun
Çok
Deniz
teşekkürler.
Hocam.
Biz teşekkür ederiz.
Verdiğiniz destekler için içtenlikle teşekkür ediyorum. Sağ olun.
Teşekkür ediyoruz. İyi
Ulan
akşamlar.
İyi akşamlar.
İyi akşamlar abla. Sağ olun.
Ülke Hocam onur duyduk sizi görmekten. Çok teşekkürler. Sağ
Bizim
olun.
için büyük onur hocam. Çok teşekkürler. Hoşçakalın. Teşekkürler hocam.
Sağ olun.